Okay, it looks like we are on air and live. So we're going to do our final presentation, hopefully for the final time.
So we are the team The Voices, and we have Olivia, Claire, and Rachel. And we are going to be discussing euthanasia and what it's like for the patient and the healthcare professional. So a little background on euthanasia. The word actually comes from the Greek roots eu and thantos, and eu means good and thantos means death. So the meaning of it is actually a good death. And in the dictionary, the meaning is stated as a good and gentle death. And then it was first coined or used by philosopher Francis Bacon in the 17th century when he used it to refer to an easy, painless, and happy death. There are 3 classifications that it can be considered as. It can be either voluntary, non-voluntary, or involuntary. An example of voluntary is when a physician gives a lethal injection to a patient who is competent and suffering from pain. A non-voluntary example is when a physician gives a lethal injection to a patient who is not competent and when they didn't make the wish while they were able to. And an involuntary example is when a physician gives a patient a lethal injection despite of their advanced directive when they're unconscious and they're still suffering from pain from the final stages of a terminal illness. Euthanasia has been legalized in 4 countries, which is the Netherlands, Belgium, Colombia, and Luxembourg. And then assisted suicide has been legalized in Switzerland, Germany, Japan, Canada, and the United States. And then the difference between euthanasia and assisted suicide is that euthanasia is the termination of a life by a doctor at the express wish of the patient. And assisted suicide is intentionally helping a patient terminate his or her life at their request. And then within the United States, it's been legalized in California, Colorado, Oregon, Hawaii, Vermont, Washington, and Montana. And then in Montana, it was legalized through court ruling. In the other 5 or 6 states, it was legalized through the legislature. And then within the different countries and states that it was legalized, there have been 3 acts that have been placed. So in the Netherlands, it was placed in 2000, and there are certain guidelines that must be met. And those are that the request must come from the patient and it must be completely voluntary, well considered, and persistent. The patient must have adequate information about their prognosis, condition, and any other treatments available to them. They must be suffering from intolerable pain, and there must be no room for improvement. All other alternatives have been considered and found ineffective, unreasonable, and unacceptable to the patient. It must be performed by a physician who has consulted in a colleague of theirs. The physician must exercise proper care to the patient, and that all data should be recorded in a written record. And then the final guideline is that the death must not be reported to the medical examiner as a natural death. And then in the Australian Northern Territories, their parliament passed the Rights of Terminally Ill Act in May of 1995, but it was only in effect for 9 months. And then the final one was in Oregon when they passed the Death of Dignity Act in November of 1994. And there are also certain criteria that has to be met for that act as well. And those include that the patient must be at least 18 years old, they must be a legal resident of Oregon, they must be able to communicate his or her decisions about their medical care, and they must be in the terminal phase of an illness and must have a life expectancy of less than 6 months. And then Claire is going to talk about the pros.
Okay, so I'm Claire, and some of my, I think, biggest points, the first one would be just like the whole discussion of autonomy. So autonomy in the healthcare is basically like choosing what you want, like the care you want. And with autonomy, I think it also ties in the right to die by your own hand. My next point would be the whole dignity point. Like Olivia had kind of touched on the death or dignity death law. Dignity is a huge part of a patient, I think. And if these patients are in a hospice setting or a medical setting and they're dying, they're losing their hair like cancer patients, they're losing weight, they're being pumped full of these drugs, that's not a good life to have. Euthanasia would decrease the suffering, and these patients actually wouldn't die full of all these drugs. A lot of people who are in final stages, terminal illnesses, they're not really there, they're not competent, they're just sometimes they're swollen from the amount of drugs they're getting to block the pain that they would otherwise have. Another thing that Olivia kind of touched on was a part of euthanasia called the non-voluntary euthanasia, and that also could actually be tied to the accidental deaths in the hospice setting from overdoses of painkillers. It actually happens a lot. Not by purpose on either side, but these patients, they're terminal, they're being pumped full of all these drugs, and the drugs actually stop their heart and end up actually killing them. Another point I had was the cost. Palliative care can be anywhere from hundreds of thousands of dollars, especially like something like a hospice house, if they were transported there, or even if they were at home, like a hospital bed at home. Hundreds of thousands of dollars for the patient, and then once the patient leaves, that's a family's responsibility. And the cost of a euthanasia drug actually ranges from $30 to $55. So if you put that in perspective, a terminal patient who's losing their dignity, they're not happy anymore, they're ready to move on, and instead of costing their family hundreds and thousands of dollars, they choose euthanasia, and there's $30 to $50 fee. There's actually a case that I talked about in our paper in PowerPoint. It was Vacco versus Quill, and it was actually a Supreme Court case, and the ruling ended up being the right of a competent, terminally ill person to avoid excruciating pain and embrace a timely and dignified death. So that's what they were kind of ruled on, that once this person no longer has dignity, like I touched about before, and they're terminally ill, they're facing this excruciating pain daily, that's not living anymore, and they deserve a dignified death. Another huge part of euthanasia becoming legalized would be the less psychological effects on family and healthcare providers.
It's me.
Okay, I was like, where does that come from? Sorry. Family effects. So if you are a family member of this patient that, let's say your grandfather, your uncle, your dad, your brother even, and they were once these strong characters, they were the head of households, and now they're basically shriveled up in a hospital bed, they can't walk, they can't eat, they have feeding tubes, they are constantly pumped full of pain meds. What kind of psychological effect is that going to have on you, or maybe their granddaughter, their niece, their daughter, their young child? Like, that's like what you would remember, as instead of the one strong person that you knew throughout your entire life, you remember this not even the same person. And for family effects, if euthanasia was legalized, it would also have another psychological effect, would be granting the patient what they ultimately wish. I think that'd be a huge psychological effect, giving them their one last choice. So yeah, another argument that people bring up is that, especially like Christians and Catholics, they have the argument that God gave life, so no one should have a right to take it away. But this quote was from a kind of like religious spiritual group called the Universalists, and they came together in a congregation, and they kind of made this little statement, and it was, When life is no longer dignified for the human or is corrupted, there needs to be a way for this human to then choose a different route. So basically it's saying one's life is no longer dignified, which I've talked about before, and it's corrupted. They're maybe crippled, they can't walk, they don't know what they're doing, they can't speak, they can't eat. There needs to be a way for this person to choose what can't really be said. So I think that also ties in euthanasia with a living will. So a lot of people, they find out they have a terminal illness, or even before that, they create a living will so that their family, their healthcare providers, they know what they want at their end-of-life care. So I think if euthanasia was legalized, it could kind of be tied in, because to have a living will notarized, you have to be completely competent. It has to be all about you. You would have had to like talk to physicians and know what kind of sorts of things happen at the end of your life and what kind of care you'd want. So I feel like if this person is just thinking ahead in life and think, what if I had a terminal illness? Would I want my family to have a pull a plug, or can I choose it myself? And then my last point would be that everyone has a right to live and a right to due process. That's in the court system all over the United States. But what about the right to die how they want? To literally, they have a right to live, but why don't they have a right to stop what they have had their entire life? So I just think between autonomy, dignity, just family effects, psychological effects, healthcare provider, because I know a lot of healthcare providers are affected when patients they become so close with, and they watch them slowly die and slowly suffer, and all I can do is give them pain meds and then watch their family there as well. With all that tied together, euthanasia should just be legalized so a patient can choose its last final wish. And then Rachel's going to go with some of the cons of euthanasia.
All right. Thank you, Claire. You did a good job outlining the potential benefits of this practice. But as we know, as Olivia explained, it's not a widespread practice. It's there, and so there's definitely other considerations to be made when discussing this topic. First of all, are the legal implications. It's, as Olivia said, it's still illegal in most states in the United States and countries around the world, meaning euthanasia or physician-assisted suicide. One of the reasons that it is hasn't been legalized widespread is because of the difficulty in regulating the practice. Part of that comes with determining the competency of the patient. So Claire talked about when a patient has an advance directive or living will and they've made their decision when they were mentally competent, that's one scenario. But there's many other scenarios, excuse me, when the patient doesn't have those documents in place and now they are in the stages of a terminal illness, they're pumped full of pain medications, they are being affected by the disease process, and are they truly competent at that point to make their wishes known? And then there's patients that, if they're not, and it's their next of kin that have to make the decision, how do we know that they're making the right decision for the patient? And are there ulterior motives? Is there a financial motive? Is there a is there some other driving factor in making that decision? And then there's those patients that don't even have next of kin. And how do you, who determines what's the best way to handle that situation? So it's certainly not an easy easy practice to regulate and make it safe for all patients. There's concern for those patients that don't choose the practice if it were available. Would they be intimidated or pressured or discriminated against because they're utilizing healthcare resources for what benefit? You know, they're utilizing the doctor's time, they're utilizing a bed that maybe somebody else needs. And then there's the potential for abuse within the system as well, that those patients that don't have somebody to make the decision for them, who's going to stand up for them? So there's the legal implications, but then there's also the ethical implications. So in healthcare, there's 4 major principles that healthcare providers abide by. One has already been mentioned, and that is autonomy. So we all want patients to be autonomous in their healthcare, be able to make decisions based on their desires, beliefs, and values. The second principle is non-maleficence, which it means do no harm. And that's basically the foundation of the Hippocratic Oath for physicians. So you can look at that principle on both sides. You know, is doing no harm mean not letting the patient suffer, or does doing no harm mean ending their life and ending their suffering? The other principle in relation to that is beneficence, which means to do the most good. And that's the same argument, basically. What's the better option for the patient in this situation, and who can make that determination? The last principle is justice, and I touched on this a little bit, but we want it, whatever practice that is occurring, we want it to be fair and equitable to all patients, and not be restricted by a patient's inability to make a decision because of their level of comprehension or inability to have access to that resource because they may be in an area where they don't have quick access to healthcare resources. So applying those principles, autonomy, non-maleficence, beneficence, and justice within this practice, it's not clear what the best answer is. There's also the emotional and psychological effects on the physicians. So as Claire referenced, some of them have their own spiritual and cultural beliefs that do not align with that practice. So it could be psychologically distressful for them if they were either forced to participate in that practice, or they may feel pressured by patients or families to participate in that practice when it's against their own beliefs. And many healthcare organizations are operated by either a Catholic foundation or another Christian foundation, and they, you know, at this point, it's not part of their religious background. So there's those implications as well. But the emotional toll on the physician, whether it's from seeing, it's emotionally distressful to obviously see a patient suffer, but there's also the psychological effects of knowing that they caused the patient's death with intent. So having that effect on the physician is also a consideration for legalizing this practice widespread.
Okay, so then a key component to euthanasia is the importance to the patient, the patient's family, and the healthcare professionals. So like Claire said, the patients want to have dignity about their life and their death. They want to have a sense of control in their life and what's going to happen to them, but they also want to be free from pain. They have been experiencing pain for a period of time, and they just want to be free of pain. And then for the patient's family, they want to make sure that they are honoring their loved one's wishes. And they also don't want to see their loved one in pain or suffering any longer than what they already have been. And then for the healthcare professionals, Rachel kind of touched based on it, and they want to make sure that they are in agreement with their own beliefs and values, but with also the patient's beliefs and values. And then they also want to make sure that they are benefiting the patient instead of harming the patient. So with euthanasia, there are clearly multiple aspects that go into it that need to be considered. And everyone in the healthcare field wants to make sure that the needs of the patient, their family, and that all the healthcare professionals involved are met equally.
Good. Oh, we got through that. It was pretty good.
That one was longer than the first time.
Yeah.
That
Well,
one
that's okay.
was 15.5.
Yeah. And I know I said things differently than I said the last time, but
I think I might have talked longer, but I don't know.
In case this doesn't work, I recorded the whole thing. So
Claire?
I just like did a video because I could see the time and the video was just like on my ceiling, and I'm like, just in case this doesn't work.
Yeah, that's a great idea. That's a great idea.
Computer or what?
Yeah. Okay, good job, guys. Let me pull up this debriefing page so we can get through that part. All right, so now we need to talk about thoughts and feelings that were stimulated by the experience, and did you sense positive or negative synergy? How are your team's confidence and presentation skills? Be specific.
I mean, there's definitely positive energy throughout. I don't know if we've ever really had any negative throughout any of our assignments, I guess.
Yeah, I think we've all, for all of them, have come together and done our parts and, you know, made it work. And you guys were both very gracious having to redo this again. I was devastated, thought I did something wrong. And hopefully it's working this time. But as we said the last time we did this, that we've been very lucky and it has been a positive experience. And we've seen each of us grow. You know, doing this in a online environment's kind of hard. And I know, Olivia, we talked about how you were quite reserved at the beginning, but you're getting confident and you know, are doing a great job. I've been talking too much. What else did it say here? So just what thoughts and feelings were stimulated by the experience. We talked about confidence. What did you learn personally and professionally about the dynamics, importance of effective teamwork? Okay, yeah, we talked about that.
I think like all the different like little tests we had to do in this class, like describing our leadership skills. I can't talk. It's been a long day. Describing our leadership skills and like just finding out like what type of like learner, communicator you are. I feel like that was really beneficial.
Yes, yeah. And we talked about, I know I had mentioned the last time about the importance of learning these skills as you go through your career. You'll have multiple opportunities to participate in small group activities, and it's been, I mean, even for me that's already done a lot, I've learned things on how to make it be more successful.
Yeah, I was gonna say, we talked about that the other night and how, I mean, for me, not really having any like small group interactions except for like within classes, that I'll definitely realize it in the future.
And then I talked about how like, well, with like the future of like medicine and how these like video chats will probably become more popular. I mean, there are kind of now, but I feel like it's going to take off from here. There's like technology everywhere, especially in hospitals.
Right. Well, and as we've seen, as the baby boomers age and there's more need for healthcare resources and the healthcare resources aren't there, that, you know, we're using telemedicine type interaction to reach all the patients that need help that may not have resources in their area. So being able to communicate electronically like this or video is going to be necessary as well.
Especially, I think I talked about like traveling doctors that like do home visits. They could video chat, kind of ask what the patient's thinking, how they're doing, and then they could come more prepared than just like showing up and not knowing anything or just talking to on the phone. Because I feel like seeing someone's face and just like their reaction, their body language, it's a lot different than just talking on the phone.
Right. Yes. Yeah, seeing their nonverbals too.
Yeah. We talked about that.
Yes, for sure. Anything else you can think of? This was an interesting project in and of itself. You know, learning all sides of the euthanasia topic, but we worked well together in coordinating it so that we kind of divided and conquered. But I felt like, the transition was smooth between starting with Olivia to Claire to me and then back to Olivia. We just seemed to kind of work well together.
Yeah, and I think I noticed it like when we were doing the PowerPoint and the paper as well.
Yes.
Within the presentation.
Yep.
I keep thinking back to like the first thing we did as a group, like the
desert simulation.
Yeah. And how we were like, what'd you put? Oh yeah, whatever, we can put that there. I don't care.
Yeah, that's a good point. But now,
now it's like when we want something, we say it, and then we're like,
well, and probably if we did that activity now, I could tell what you're going to put, Claire, and what you're going to put.
Oh, and then our poor little member who just lasted 1 week.
Yeah.
The boy who like put like the book of like what to eat first, and we're no.
I'm like, you don't need that. You can survive a day without food.
I was like, no, what are you doing? That's like the last thing. You're not gonna read a book in the middle of a desert.
Yeah. So. All right. Well, anything else you guys can think of to touch base on? Okay. Well, look at your the presentation in the paper and see if you have any final edits to it. Otherwise, I'll probably try and submit all this stuff tomorrow night. I got twins. My 5-year-old twins are going to be here Saturday, and you can't really take your eyes off them.
No. I work with a lot of twins. I get that. I open scissors with twins too. Yeah. They'll twin you for sure.
Yes. So
this worked this time, so that way
and I have it recorded if it didn't.
All right. Very good. We have a backup.
Recording the debriefing.
Awesome. Good idea. All right. Well, thanks, guys, for all your work on this, and hopefully we'll get a good final grade. And it's actually, like I said, it's been a helpful class, and I think everybody does have to take it in the program. But
yeah, we talked about having it be like one of the first classes.
Yes, because it definitely has valuable content that you're going to.
I think it's going to be like really beneficial for Olivia because she's not even technically in like the college scene. She's like her first class. Yeah. And I know I've used these skills a lot, and I'm not even fully in the medical field yet.
Right. Yeah, they will definitely be useful. So, all right. Well, good luck with the rest of your classwork this semester and the next semester.
Hopefully this works.
No kidding. All right. Thanks, guys.
Yeah,
bye.
Stop it. Bye.